Hi everyone, I am Francesca Cerutti, and today I would like to talk to you about a simple and predictable way of shaping root canals with the Fanta Essential kit developed with Style Italiano Endodontics. When we talk about root canal treatment, we have to know that despite the industrial advantages have given us a lot of instruments in order to simplify our therapy, our objectives remains the same. So we still want to shape, clean, and fill three-dimensionally the root canal system, as you see in the short video. Why do we have to take care of shaping in the correct way the root canals? First of all, to remove the pulp and the debris that are inside of the root canals. Then we have to shape in order to improve cleaning, because with the shaping we enlarge the root canals, allowing a larger volume of irrigant going to the apical third, where we know that the cleaning is essential in order to obtain a good result. And then we also have to shape in order to make obturation easier, because it's easier to obturate a tapered shape despite obturating a very irregular shape, as it is the shape of the root canals that are not shaped. What are the phases of shaping? First of all, the correct access cavity, because we have to remember that without a correct access cavity, we cannot achieve a good shaping, because we will face a lot of difficulties that will jeopardize our results or make our job extremely harder. So, first step of shaping is correct access cavity in order to gain a straight line access to the root canals. Then we have to pre-flare, it's pre-enlargement of the root canals that allows our instrument working in a safer and better way. Then we have to make a glide path until the working length. And then we have to shape the canals and decide the finishing of the apical third. So what is the philosophy? First, as you see, the access. We changed the way we perform the access cavities in the last decade, because we switched to more conservative shapes. But what is, as I said before, that every instrument works in a straight line from the crown to the apical third, because in this way we will have a smaller amount of dentine producing stress on the instruments, and we will have an easier job. With the access, we want to remove the pulp and the debris from the pulp chamber, because we have to remember that bacteria can stain the pulp, and if we do not remove, for example, the pulp horns, we will have a higher risk of failure of the endodontic treatment. Step by step, what are we doing with our shaping? We have to proceed considering the coronal third, then the middle third, and just as a last step, the apical third. We do not have to rush trying to get to the apex immediately, because in that way we just risk to break an instrument or make ledges or make blocks. So we have to take it easy and proceed step by step, third by third. We have to remember that in the first step, we have to just flare the first 5 millimeters of the root canal and pre-enlarge before getting to the next third. Then we can just record our working length and establish a glide path, a path that guides our instrument from the crown straight to the apex. And what kind of instrument can we use to do so? We in general use small tapered rotary files with a tip between 10, 12 or 15, and then we have just to decide to shape the corona 2/3 and then bring our instruments to the apex and choose in function of the anatomy of the tooth which is the final diameter and taper of our preparation. And then we just have to clean and fill, and then to follow up in order to check if the lesion healed, as in this case, or if everything we did is going on correctly. The biggest nightmare of an endodontist in general is to break an instrument, because we can have a lot of problems. But why do rotary files break? In general, they break because of flexural stress, torsional stress, taper lock, or cyclic fatigue. And cyclic fatigue is kind of easy to avoid because we just do not have to use the same instrument for too many times, but just discard it when we know that probably the alloy has been stressed enough. I take as a reference 5 root canals, but sometimes I use an instrument for a single canal, and then I discard it because I know that in extremely difficult cases, then the instrument has worked enough. And so it's better to throw it away and use a new one. Why? Because if I break it, I'm going to lose a lot of time, make a lot of effort, and maybe not to attain a good result. So it's better in that case to just prevent the problem and discard the instrument before stressing it too much in the root canals. Another problem is a taper lock. When we use an instrument that is too large for that particular root canal, the tip just remains blocked into the root canal, the instrument keeps rotating, and then it breaks. Because we followed the wrong strategy and we did not pre-enlarge coronally before inserting the instrument into the root canal. A simple way to make shaping going smoothly is to establish a glide path, which is, as I said before, a smooth path going just from the crown to the apex with a small taper instrument. There are a lot of benefits in achieving a glide path because the shaping of the canal will be optimized, we will reduce the risk of fracture of the files, we will respect the root canal anatomy, because if everything goes smoothly, the instrument will follow the path we established, and with rotary files is extremely easy, because with the nickel titanium alloys, the instrument is going to follow the shape of the root canal, so we will be extremely conservative and we will respect the anatomy of the tooth. The risk, paradoxally, were using stainless steel files because they created a lot of ledges or blocks, or in some cases, when the clinician insisted too much in working, they created a wrong path going to a perforation, or for example. And the cause were the stiffness of the instrument and the active tip that was cutting and so creating ledges or blocks. With a nickel titanium rotary instrument, this is not going to happen unless we do a big mistake or we push too much. So how is this essential kit composed? We have 4 instruments: purple, yellow, red, and green. The purple is a particular instrument because its tip is 13 and the taper is 0.3, so it's thin enough to establish a glide path, for example, but still it makes a nice pre-enlargement coronally. Then we can switch to the yellow 2004, red 2506, and if we need to enlarge the apex further, we can use the 3504, for example. What is the peculiarity of these instruments? They are made by AFR wires, so that means they have a double S cross-section and a flat design. Their tip is non-cutting, so we do not risk to make wrong path while using this kind of instruments. The benefit of this wire is that it's extremely resistant to cyclic fatigue, so it's easy to use, it's cutting enough, and the shape of the cross-section allows the debris to come out coronally, so we do not have to just stop and wash and then verify the patency every time we use an instrument. So it's time saving for an endodontist. And then they are safe, just because the non-cutting tip. What are the parameters that we have to follow? In general, we can use them at 4 to 500 RPM. How do we choose between 4 and 500 rolls per minute? The easy case with very straight canals can be done with no problem at 500 RPM. For the more difficult or complex cases with double curvature, if you feel safer, you can just decrease a little the number of rolls per minute and switch to 400. And the torque is like 2.5 newtons. How do we use in practice these kits? Preoperatively, we have to decide whether our case is wide and easy, regular, or narrow and difficult. In this way, we will use the correct approach and the correct combination of files, because in straight and wide canals, we will use a different strategy than in canals with single or double curvatures or thin or calcified canals. So we will see them one by one, step by step. Independently from the case, just do the correct access cavity and then scout the coronal 2/3 of the root canal. If you like manual files, use manual files. Personally, I prefer a mechanical scouting in 95-96% of cases. So we just scout the coronal 2/3 of the root canal. Then what happens? In wide and easy cases, we can just go straight to the working length with our manual 10K file, and then go with the 1303, 2004, 25, 35. We just bring all the instruments straight to the working length. In this video, I had to make a rearrangement of lateral incisors, so the canal is easy, wide and easy. I just, in a first appointment, removed the gutta-percha, but this tooth was obturated with the carrier-based technique, and the carrier was stuck in the apex. So, in a second appointment, I just took a loop device. I engaged the plastic carrier of the thermofill, and then with some effort, after some attempts, I managed to remove the plastic carrier. And then, since the canal was already pre-enlarged, I just removed the remnants of gutta-percha with a retreatment file, and then after irrigation, I took the working length with the number 10K file, and then I used at the working length all the sequence of the essential kit. So you can see I go with 10, then with 20, just a couple of strokes. I use the peeking and the brushing motions in this case, just to try to touch the walls of the root canal, but the instrument came out clean. So I stepped to the 3504, I irrigated, I did my cleaning protocol, as I always do with the ultrasonic activation of the irrigants, and then I proceeded with the filling phase. So I checked the fit of my paper point. In this case, it was size 45, so I had to enlarge the apex a little more before filling. And then this was the first time I used a bioceramic sealer. I wanted to try a bioceramic with a modified warm gutta-percha compaction. So I just cut the tip of my gutta-percha point and use a plugger to pack the gutta-percha. You can also use bioceramic with a single cone technique. It works pretty good. And you see the immediate post-operatives, the 6 months, and the 1 year follow-up of the case. the endodontic lesion healed, the periodontal lesion not yet, but the patient is asymptomatic, so we're doing good. What happens in a regular case? In a regular case, we just do something more in the pre-flaring case, because we want to pre-enlarge coronally before getting to the working length. So we use a manual file short to the apex, and at the same length we pass with the number 13 and the number 25. Why don't we use the 20? Because the case allows us to just make a jump of one step of the treatment. But if we need, we can also make the sequence 13, 20, 25. There is no problem at all. Just remember to pre-enlarge coronally, so we are working in the coronal and then in the middle third of the root, and just after that, you go recording our working length with the manual number 10K file. Once we found the working length, we just have to transfer it to our number 13 file, and just with the picking motion, in this case, bringing it to the working length. Okay, I'm there, and I just remove it and change. Between the files, it's nice if you want to irrigate, just to remove the debris. And then, even in this case, I jumped from 13 to 25. I bring my 25 to the working length with no effort. If I had found some difficulties in proceeding with this instrument, I would have used the 20 in between them. And since the anatomy of the canal allowed me to do it, I used also a 35/4 in order to have a better fit and a better shaping of the apical third, because the spires of my 25 file came out completely clean in the last 2-3 millimeters. So that meant that I did not actually shape the apex of the root canal, and so I had to switch to a larger file. So in this case, I do exactly the same, clean and fill, and this is the postoperative X-ray. What happens in narrow and difficult cases? For example, in this case, I had to do like everything, because I had to do an endodontic treatment on the second premolar, which had 3 roots with 3 separate root canals, a retreatment on the first molar, and a treatment on the second molar. So I did the easy thing first, the second molar and the retreatment of the first molar, and then I focused on the second premolar that had these extremely narrow and thin root canals, so it had to be approached cautiously. And as you see, I managed to treat it, and then I sent it back to the referring dentist that made the coronal restoration. And you see the 1-year follow-up in the last slide. How do we do the treatment step by step? Well, first of all, we have to consider the pre-flaring phase that will be done with all of the instruments we have in the kit, up to the red. So, K-file, purple, yellow, red, short to the working length. Then we will record our working length, make a glide path with the number 10K file, for example, and then just get to the working length with the purple instrument. Do not rush while doing this, because you're working in a narrow root canal. As you can see here, we have 4 root canals, and I'm doing what I told you before. So with the purple file at 400 rows per minute, in this case, I'm just trying to penetrate into the root canals. I'm removing the pulp with the spires, because they have a shape that allows me taking the pulp out, and this is nice. I'm trying to approach also the mesobuccal 2 canal, but I'm not forcing the file to proceed. Then, after some attempts, you see that my file is going in deeper, and I can switch to the yellow one. As you can see in this image, I work with the irrigant into the root canals, and then I just get in with the picking motion with the yellow file. I do not try to go immediately to the apex because the canals are narrow, they are curved, and I don't want to make blocks or to break a file, even if these are resistant, so I would have to push a lot to break them. But anyway, I'm just trying to be as conservative as possible and to respect as much as possible the anatomy of the root canals. So I do my pre-flaring in the middle and coronal third, before even trying to get to the working lead with a manual file. Once I'm satisfied in all of the root canals of my coronal pre-flaring, then I can get the working length. And then I shape with all of the instruments to the working length, but I can stop to the 20 if I'm finding a difficulty in proceeding, because we do not need to enlarge more, and because while stepping to a larger taper, we would risk to break an instrument. So remember to always play it safe. As you can see, another case with a double curvature because the second molar has very long roots and it makes two curvatures in the apical third. So I have to approach it very cautiously. As you can see, I pre-enlarged, I managed to take the working length, and then I just shaped, cleaned, and filled. Obviously, in the distal root, which is straight and easy, I could use the wide and easy protocol, while in the major roots that were extremely more complicated, I used the narrow and difficult protocol. So different protocols but same instrument in order to manage the case. So thank you very much and have a good day.